Uh, Good afternoon, everyone, and thank the organizers for inviting me. So I'm asked to review this abstract, which is the KEYLYNK-010 study, which is pembrolizumab plus olaparib versus abiraterone or enzalutamide for patients with previously treated metastatic CRPC, a randomized open-label phase 3 study. This was presented last year in the ESMO Congress at Paris. So, to introduce, we all know the different standard of care options in metastatic CRPC. However, in certain molecularly selected subgroups, after a few lines of treatment, we have the PARP inhibitors and the immunotherapy coming in. 1% of patients, we may have MSI high or TMB greater than 10, where pembrolizumab can really work well. And HRR mutations are patients which will be around 20 to 25% of patients where PARP inhibitors and possibly a platinum may work well. So KEYLYNK study looked at the combination of pembrolizumab and olaparib in an unselected population in third line. So this was the study design. Patients which were included had to be confirmed CRPC, and they must have had progressive disease after 2 lines of treatment, one of which must be docetaxel, and one would be a novel hormonal agent, either abiraterone or enzalutamide, but not both. They must be having a good PS, and they must be having a tissue sample for biomarker assessment. Patients were stratified as what kind of NHA they received, either abiraterone or enzalutamide, and whether they had measurable disease at baseline or not. So patients were randomized 2:1 to pembrolizumab plus olaparib, where pembrolizumab was allowed up to 35 cycles, and olaparib at a dose of 300 twice daily, versus either of abiraterone or enzalutamide based on what they had received earlier. And the primary endpoint was radiographic progression-free survival, and a secondary endpoint was overall survival. The key secondary endpoints were time to first subsequent therapy, overall response rate, and safety. I would not go into the details of the statistical analysis, but they had pre-specified 2 interim analyses, 1A1 which was for radiographic PFS, and 1A2 which was for OS. And this trial did not meet the primary endpoint and was actually stopped in between after the 1A2 data cutoff. So the median time from randomization to data cutoff was 18.7 months. So these are the baseline characteristics, and you can see that patients were around 70 years of age, 50% had PS1, 55% had received abiraterone, and 45% had received enzalutamide. 99% had received docetaxel. So quite good treatment they had received. Gleason's was 69 in around, was 8 or more than 8 in 69. But they did not have much information as to what was the visceral metastasis status, what was the PSA, and what was the response to ADT, what was the time post ADT progression in these CRPC patients. HRR status, so again around 25% patients were HRR mutated in both arms, 26% in pembrolizumab plus olaparib arm, whereas 22% in the novel hormonal agent arm. And BRCA mutation was around 9% to 10% in both the arms, so similar. They also informed the PDL1, which was 24% around in positive in both the arms, but they did not have information about the TMB or the MSI. So this is the primary endpoint result, and we can see that the primary endpoint was, the graphs are quite one upon each other, and there was no difference in the PFS with 4.4 months in the pembro plus olaparib arm and 4.2 months in the hormonal agent arm. But if we look at the subgroup analysis on the right side, we see that in the BRCA mutated subgroup, we can clearly see that the radiographic progression-free survival was met with a hazard of 0.4, and this was also somewhat met in the HRR mutated subgroup with a hazard of 0.69. So just as what Dr. Vamshi was saying, that BRCA mutated you had a very good advantage, but in the HRR mutated you had some advantage. But this was a very small subgroup analysis, probably, which is applicable to only 25% or 10% patients. In the PD-L1 positive or negative, there was absolutely no difference in the outcome. If you look at the overall survival, again, there was no difference in the overall survival, 15.8 months versus 14.6 months in both the arms. And here too, what we see that the BRCA mutated subgroup, the overall survival was better with a hazard of 0.52. And the only other subgroup which had better overall survival was North American patients, probably because they have better access to other treatment options. Again, PD-L1 positive or negative, there is no difference. And HRR mutated, again, just as Dr. Vamshi was saying, the advantage, OS advantage had gone. So the PFS advantage was there, but the OS advantage was not there in the HRR mutated subgroup. If you look at the other secondary endpoints, time to first subsequent therapy, this was also not met. It was almost equal. And when we look at the subsequent treatments that the patients had received, 48% of patients, around 45% of patients did not receive any subsequent therapy. And olaparib or PARP inhibitors, which are important treatment options in BRCA mutated 10% patients or HRR mutated patients, which are 20-25%. Here also we see that this treatment was not given to the opposite arm, that is the control arm. If you look at the response rates, so yes, response rates were higher in the pembro olaparib arm and the disease control rate was better. But then you see there was four patients who had complete response, which is 1.6%, and 1.6% are those patients probably which were MSI high or TMB high. So probably this doesn't say anything about the advantage of pembro olaparib. Toxicities, so yes, although the all grade toxicities were similar, but grade 3 toxicities were almost 20% higher in the pembro olaparib arm. Discontinuations were higher and death rates were higher, which is significant. Treatment side effects are similar to what we see in olaparib or pembrolizumab. So this was the author's conclusion that the phase 3 KEYLYNK-010 study did not show any statistical significant improvement in progression-free survival or overall survival with pembrolizumab plus olaparib, and the study was stopped for futility. ORR was higher, safety profile was consistent, and ongoing studies are investigating other pembrolizumab or olaparib based combinations. What is my critical analysis is that I would compare this study with the PROfound study. And what I see that the trial design was very similar to PROfound except the patient selection. This was an absolutely molecularly unselected population which was included here, and there was no information on the MSI and TMB status. Also, key prognostic factors were not included. Patients were well treated. They were 99% were exposed to docetaxel, whereas in the PROfound study, almost 65% were exposed to docetaxel. Post-progression treatment was inadequate, just as I said, and there was no PARP inhibitor in the control group. 25% would be having a HRR mutation even in the control group, but yet there was no OS benefit in the treatment arm, whereas there was a significant benefit in PROfound study in both cohort A and cohort A plus B, if we remember. Subset analysis did confirm that the similar benefit of treatment was there, which was driven by the HRR positive and BRCA mutation subgroup, just like in the PROfound study, and toxicities look similar. So Monday morning practice, my key takeaways would be metastatic prostate cancer, send germline mutation for all, and NGS or somatic mutation panel including TMB, MSI, HRR in the affording patients. Pembrolizumab plus olaparib, it is costly, it is potentially toxic, and we cannot use this in an unselected population in today's era of precision medicine. PD-L1 is not a good biomarker for immunotherapy in prostate cancer. There is no use of doing PD-L1, and we must try to expose our patients to multiple treatment lines including cabazitaxel and radiopharmaceuticals for best outcome. Thank you for patient listening.